Hi, my name is David Keegan. I'm an academic family doctor here at the University of Calgary. We're talking now about how to write or document your admission history and physical. And this also applies to major physical exams of any sort of type. Okay, so first of all, think about what the key purposes of doing this are. We talked in other videos about the importance of tracking information for your own sake, tracking information for the sake of other healthcare providers, and to be a document of how things were so that in the future, if there's any sort of medical, legal, or quality of care issues, we've got it all documented. And with those things in mind, you need two elements. You need clarity, you need accuracy. So the clarity will have impacts on how you set up your note, how to write it, or frankly, print it to make sure it's actually readable, so that there's clear headings and all that kind of stuff. And then the accuracy is making sure that you're documenting things properly so that you've got, it's not just intermittent chest pain. No, it's, chest pain lasting 10 to 15 minutes, 4 episodes over the last 24 hours. So that there's, you nail down different things. And it's not just symptoms. You also nail down somebody's history in terms of like their previous history. If they had surgery, going the extra mile and finding out what was that surgery and so on. And is like medications, is nailing down dosages and so on and what they're actually taking right now. So these are the bits, these are the kind of the two key principles that should be flowing through all of your documentation of any type, but particularly for admission history and physicals or major history and physicals. So in part one, we're going to talk about the history. How do you actually document? How do you actually write it? So whether it's an electronic record or a paper record, the principles are actually still the same. You still need to be clear. You still need to be accurate. So first of all, you'll get the patient ID up front. Now the ID is usually their name is already stamped on things, so you're going to have already checked to make sure you're in the right electronic record or you've got the right patient stamp or name on the paper. But on the ID itself, usually it's like 29-year-old female, and so with something, so like with right lower quadrant pain times 10 hours. Great. And in the ID, it sort of just gives the overall picture. That's great. Now, you might also in the ID include anything that has a massive impact on how this patient will be cared for. So at first glance, this might seem to be an essentially previously well or fairly healthy 29-year-old. But let's say if the person has severe adult developmental disability, then you would probably have written that in up here. So 29-year-old lady with severe developmental disability, and you'll have written it as part of a full sentence because that will change things. That will change. I mean, if somebody's got a profound developmental disability and yet they're showing up with abdominal pain, that might be somebody who rarely reports pain, who've had different sorts of infections or whatever. So this could be even more serious than what you think. Or if it's, say, somebody who's let's say a different kind of patient who's homeless. If somebody's homeless, that dramatically changes their care plan and what's going to happen to them and what's the best way to do things and to set things up so that they're going to have the best possible outcomes for their health. And if somebody had cancer, like if somebody has active metastatic cancer, then yes, you would include that there too. So if you've got a 29-year-old lady with known metastatic cervical cancer, with right lower quadrant pain times 10 hours, that is a dramatic change to what would normally seem to be a fairly straightforward, serious, but what might seem to be at first glance to be a fairly straightforward patient. So include in your ID kind of identification, include anything that's going to massively change their care or their assessment. Next, goals of care should appear up here. Now, for many patients, we're just going to assume It's full care, full resuscitation, and so on. But nevertheless, it's good to document it. And so different jurisdictions use different things. In Alberta, we've got a multi-level system. And so there's resuscitation levels, medical care levels, and comfort care levels. But whatever it is, you should make that clear. And particularly if this had been, like, say, somebody with a known serious, unremitting disease like cancer, metastatic cancer, this person may have had a very different goals of care than somebody else who appears with these kinds of symptoms. Next, you'll do your history of presenting illness. So this is the story of this right lower quadrant pain. So onset at, let's say, 10 o'clock, 1000 hours. It could be initially mild, increased severity, 10 out of 10 pain, last 2 hours. You'll notice that I'm using point forms a lot. And that's handy because it goes back to that earlier issue of being clear to help yourself and other people find the information they're looking for. So on paper or electronic record, point form can be quite handy. And I've always found it very handy that you have a major concept per line. So along with this, let's say, the type of pain. So it's like it's a sharp pain. And then any aggravating features you could put in here, any things that make it better, relieving factors could go in here. And then you would also include in a history of presenting illness, for any body system, you would include the other things that are typically likely to go along with. So you might say, like, no vomiting, no diarrhea, etc. I'm not going to spell them all out now. It's hard to do that with the video camera and so on. But you would record the different other things that might typically go on with this. Now, if you're an astute observer, you might be thinking there's a really important thing for a woman with right lower quadrant pain versus a man. The issue of, is there a potential pregnancy at play? And so you would include that for sure in the history presenting illness. If you haven't yet got a beta HCG test back, if you have, like, let's say the patient arrived to emergency room and they already had a positive beta HCG done at their family doctor's office, and that's known, that would again be one of those big issues. A 29-year-old lady with positive urine beta HCG with right lower quadrant pain times 10 hours. Okay, that totally changes your assessment and approach to this patient. But if it's not yet known, you would put in here, whether like plus sexually active, maybe trying to get pregnant, or known to be pregnant, or whatever. So, I'm just going to erase this bit, because then we move on down to the other sections. So once you've sort of like told the story about the history presenting illness, then you got to still set the picture for the patient's full background health. So past medical history, and describe what it is. Maybe she had an appendectomy, and you put down the year, or maybe there's not much, or maybe she's got asthma, and it's good to put some sort of commentary. So if it's asthma, oops, missing a bump. If it's asthma, you should put down some context around that. So if it's like well-controlled, never hospitalized, let's say on PRN beta-2 agonist, so like salbutamol, PRN salbutamol, or albuterol, depending on where you live. On PRN salbutamol only uses 1 per month. Then it's very clear this is very mild asthma, as compared to somebody who's been in and out of hospital with asthma and is on high-dose treatment and so on. So past surgical history. So you can lump sometimes surgeries, like I did earlier, into past medical history, or having it teased out. Different people like different things. It's probably better to tease it out separately, and then that way it just sort of is clear. So maybe she's had no previous surgery. Great. And then meds. This is where you can really hustle and do some good work. So it's everything. It's prescriptions, so any prescriptions, and then you should hunt down what the dosages are. If they have the pills with them, that's amazing. Look at the pills and confirm, okay, so these pills, it says take twice a day. How many times a day are you taking it? Twice? Okay, great. Or sometimes they say, oh no, well it says twice a day, but my doctor had me cut that down to just once a day now because I was getting too dry. Oh, like if it was a diuretic, and so on. And so looking at the bottles, discussing them with your patient is really key to reconcile the medications. Medication reconciliation is a really important thing to do. Sometimes you have to call the pharmacist. Never just take, the patient says, oh, I'm on furosemide and I'm on digoxin and I'm on metoprolol, and just write down those names. No, as a learner, unless there's a critical scenario, you should be hunting down those numbers, find out what the actual drug dosages are from the pharmacist ideally. Call the pharmacist directly is usually the best way to get it. Because there's been, sometimes some research shows that while it might be on provincial or state tracking mechanisms, the actual 50% of the time or so, there can be errors between what's shown and what the person is actually taking now, because there's been things have changed since then. So you want to find out what the medication use that the patient's been taking right now, but it also includes over-the-counter drugs, like any vitamins and so on, if they're taking like naproxen, anything over-the-counter, and also includes like any herbs, you know, or any natural therapies, whether they're getting EDTA, whether they're taking, you know, St. John's wort, whatever. All that's in there. You should always document allergies. And again, if you want the details, so it's not just penicillin, but you have to document the reaction. Make sure you always document the reaction, because you never know when your record might be the best record available and people are going to this to figure out, do we risk penicillin or not? And if you don't have the reaction displayed, it can be very hard for people to make that decision. But if the reaction was simply, you know, a rash reaction, then great. But if it was tongue swelling, then that's going to be a very different thing. And I don't think anybody's going to be giving that patient penicillin. So allergies, and then you also want to document cigarette use, you want to document alcohol use, and you want to document any drug use of any type, be it like injectable heroin, be it marijuana, whatever. You'll notice that I make the headings really clear. That is critical. Making your headings really clear is so important to help other people find the information they need when they're looking at your note. That is so important. You might not be able to believe it, but it's true. And then finally, and this is actually a really critical piece of things as well, a patient's social context. Sometimes people call it social history. Now, the social context is critical for two reasons. One is that it helps you understand the patient, because sometimes bits in their context change how you understand what's going on with them. And number two, it can help change how you manage them. So for instance, if you find out in their job that they work as a police officer and they're here with, you know, upper diffuse back pain, you know once you've cared for a lot of police officers that is actually largely due to sitting in the chair and sitting in their car chair, their car seat, turn to the side, typing on a laptop. Trust me, if you don't care for police officers, it happens all the time. Not that you would discount other things, you still want to make sure it's not other things, but knowing that social context gives you immediate insight into likely or possible causes. Similarly, if somebody's an IV drug user and comes in with back pain, you know that, oh, that could be an epidural abscess. And it's not because the way they looked, it's because of that simple bit of the context, the fact that they're homeless. Now, this can be a big thing, but there is a nice 5-point lens that was developed at the University of Western Ontario to come up with, you know, what's a nice way that captures most things that are going to affect either the assessment or the management of the patient. And they are checking into somebody's work or activity. You know, what do they do? Are they retired? Are they working as a teacher? What do they do? Number two, checking into their family structure and their relationships. with whom do they live, that sort of thing. You know, who are they close to? If they break their ankle, is there somebody that can help them or not? There's all those sorts of issues. And also just understanding like how much support they have. You know, if they're going through a rough time, are they totally on their own? You know, you might send one patient with depression to a psychologist and somebody else you won't, precisely because of their differing levels of supports through supportive relationships. Next, any cultural or religious issues that would impact assessment or management, you know, with regards to, you know, like maybe like some beliefs over immunization or whatever that you might need to negotiate around, or the use of blood products and so on. Their level of resources, basically their income, but it also includes, do they have a house? Do they have the ability to get things done if they need a specialized piece of equipment? Can they get it, and so on? And then their level of functioning. So you might have, say, two 85-year-old ladies, both with an ankle sprain, and for one person, you know, it's a problem, but they've got a higher level of functioning. They can get themselves easily to and from physiotherapy. They can manage all this. And for somebody else, this could be, they might have already been quite frail and actually have limited ability to engage in society. They've become quite shut-in and so on. Those are two totally different patients with the exact same diagnosis and the exact same age. So this level of functioning is key. Now, sometimes your history will get bigger and broader. So for certain conditions or certain age groups like pediatrics, you might want to get into the genetics, might be there. And you know, you might be drawing a pedigree. And for other groups, there might be some other bits and pieces as well that come into it. So in general, with the history, you want to lay things out nice and clearly. And on all features, you want to get a level of detail, but try to present it in a clear and accurate way. Make sure your subheadings are incredibly obvious, the different headings and so on. And then you make clear, you know, if there's like different elements or whatever that you're exploring or a lot of detail, instead of having large run-on paragraphs, it's usually better to have it in point form because it'll help you and other people find the same information. So when you're finished this, if you want, you can go on to part 2, where we're going to be talking about how you document the physical exam and also how you document the assessment and the plan. Thanks.